Okay. Go ahead and call the meeting to order. Roll call. Cindy,
Here.
Heather,
Here.
Marlene,
Here.
Joe,
Here.
Jim. Kimberly is absent, or no, she's just not here. Okay, we have approval of the agenda, and I would like to ask if we can add Wolf's water plan to that agenda somewhere.
I move that we approve the agenda and include the water system isolation and RPZ assembly replacement discussion.
All in favor?
Aye.
Approval of the minutes for April 24, 2025, hospital board minutes.
I'd like to make a motion that we approve the last meeting minutes from April 24th, 2025.
Second.
All in favor?
Aye.
Do we have any visitors' comments?
Jared, yeah, this is Roy Roundtree with Bettesworth North. I just wanted to thank you for the invitation to this month's board meeting and let you know I'll be hanging out here. I do enjoy the conversation, and I'm really very excited to have the work building coming online, and I'm sure that Wolf is as well. It'd be nice to handle some new systems. So I'll be here in the meeting. If you guys have any questions on anything that I can respond to, I'd be happy to respond.
Okay, thank you, Roy. Any other visitor comments? Board member comments.
I didn't hear a second on the approval of the agenda, so I'll second that. Back up.
Moving on to committee reports. Do we have a resource committee report?
And I'm going to breeze through some things because I see Jason is here. We have filed our 990 tax return prepared by a Ketchikan CPA, and the document is fairly voluminous at 70+ pages and uses our recent audit information. And because we are a 501c3, there's some specific items we're required to submit, and there was some salary and other bits of information in there if anybody wants to go through it. In going over our financial statements for the last month, all our key volume numbers are up except lab tests. And as mentioned last meeting, this reflects that we did not have a health fair this year, which inflates or increases the numbers. Even so, revenue is up in large measure due to inpatient volumes, and the 340B program is showing a positive impact to finances as well. Joel gave kudos to the hospital business office for the excellent job they are doing with account receivables. April was the highest revenue in the past 10 to 11 months, and accounts payable are reasonable, and we are paying invoices rapidly because our cash flow is good, and days in AR are declining. We have some funds in the bank that we may want to move to investments, and they could be pulled back quickly if the need arose. And we've also finalized purchase orders for the work building furniture, and payouts are anticipated in June. And the committee discussed what's happening in the grant world, our coordination with the borough to obtain funding for projects, and other topics included typical industry costs and salaries compared to PMC, increases in utility costs when PMC takes responsibility of the work building from the contractor, and how depreciation of the work building and the MRI will have a positive impact to our cost report in the future. The budget is not complete yet, but Jason will be in town in June for a budget deep dive, and the budget will be up for approval by the board in June.
Thank you, Cindy.
I just wanted to note that Board Member Roberts is present.
Okay, thank you. LTC report.
Have that for May 21st and also April 16th that I didn't report on last month. They went through a lot of different action items. They need to replace the fall prevention system, and a new one will soon be ordered and in place. When you have elderly people that have compromised mobility and balance and confusion, that's a real necessity. You'll be hearing more about the sewer line repairs and inspections that have been ongoing. There's a term polypharmacy that refers to people that are on many, many different medications, and often elderly people in long-term care are on a great many medications prescribed over the years, and some may be unnecessary at that point, some may be impacting other medications that they're on, and so they're working on reducing the number of medications people are taking and having active policies in place to be monitoring that. The psychiatrist that has been providing services by telehealth will be coming for a visit, and he will be seeing some of the long-term care residents when he's here. They currently have 14 residents, many of whom need one-to-one staffing for some of the time or a lot of the time. And so they've had to hire an additional nurse's aide to handle the number of patients they have now. There is a new emergency app call system that will be able to coordinate with the police department very quickly in any kind of dangerous situation. And finally, as they've been working for quite a while to try to get a physical therapy technician working in long-term care, and there is someone now that's hired and is gone through onboarding and is actually working with the residents now to improve their mobility and their other physical skills. That's it.
Thank you, Marlene. CIH,
Yeah, this is Joe. I attended the Critical Access Hospital Committee meeting on May 21st. Some general updates were provided by Phil about the meeting he attended in Washington DC, which focused on safety and quality in hospital care. We went over the action item list, talked about the digital formulary, an active policy list that was being worked on for eventual approval by the board, health maintenance tab, skilled stay auto reminders, and also an opioid reduction project, and progress on those action items is ongoing. Went over several reports, started with the incident report. Phil showed some slides from the DC visit regarding safety. Cancer screening prevention has improved. Collaboration and communication was discussed at the meeting about the key to improving safety. For PMC proper, the incident report showed no major trends. There were a few incidents in April and May, but they were below the previous 2-year average. Got a report from the medical director on diabetes and A1C. There was some newer info on referrals presented, and physician availability was discussed. Primary care management, we reviewed the amount of traveling nurses. The swing bed area is really busy. There's an average of 4 skilled swing beds in the last month, and they're working collaboratively with home health. Also, we discussed issues with patients that don't qualify for long-term care, but don't have any other places to go. Went over some other reports on infection control therapy, the facility, report from radiology. One thing on the radiology report that was discussed was the magnet for the MRI machine, which is due to arrive in mid-July. Had a report from the lab and also on nutrition. Nutrition's been busy. due to acute and extra folks around. Had reports from wellness, materials, pharmacy, emergency preparedness. And last thing that was mentioned was Phil brought up on the finance side that the PMC's dropped 20 days of accounts receivable with the new org structure in the finance office. That's all I got.
Thank you, Joe. I'd actually like to do, everyone get a chance to look at the water system replacement list that is, it's basically, it looks like a list of what's going to be taking place. Is that tomorrow? Yes. And if we could ask about getting a plan. And this is what was submitted. It looks like it's going to take place soon. So were there any questions on that? For Wolf?
Just prayers.
Do you have any comments on it regarding what's going to take place tomorrow?
Yeah, Wolf's mic's not on.
Use one of the ones in the back.
It's working now.
Sorry about that. Oh, sounds better. So yeah, there is always a chance for something that we are not accounting on, but as of right now, I don't see that happening. So I just kind of want everybody to know that, yeah, this will be taking place tomorrow at 8. Yeah, hopefully nothing major goes wrong, but we've kind of accounted for just about everything that myself and both Chris can possibly think of. Yeah.
Is that 8 in the morning or 8 in the evening?
It's 8 p.m. and it's
PM,
scheduled to be a
okay, that's
6-hour
good.
shutdown.
Yep.
Thank you, Will. Okay. Regarding Elizabeth Hart's report for swing bed management, were there any questions on that report?
Question on the comment about reviews with the Seattle hospitals for swing beds or referrals.
Yeah,
What is that about? Does anybody know?
Can you tell me what page that's on?
It's under community engagement, under her report.
It says page 10.
10, okay. Yes. So, third bullet on the community engagement.
I'm assuming it's just pretty standard when they're looking for referrals from facility for skilled patients. Swing bed is skilled patients, so there's a group typically that Elizabeth sits on a network, and they look at referrals throughout the state and also in close proximity, similar to Seattle, Swedish, Virginia, Mason, Harborview. So I think it's pretty standard.
So we're getting people coming up from there for rehab, et cetera.
Can be. Sometimes referrals for people from Petersburg that have something done in those areas, and they're referred back for rehab potentially.
Oh, okay.
I can get more detail if you'd like, Jim, on that.
Yeah, I was just curious. And and 2 bullets down, is referencing keeping in touch with Bartlett.
Yes. So Bartlett, I mean, there's a network of facilities based on procedures that are done, and swing bed is a rehabilitation procedure where they come in and they rehab through the swing bed program.
Okay. Thank you.
Anyone have any other questions on that one? I did have one comment that I wanted to ask, and with the increase in patients that we've had, and over a long period of time, is there any concerns about our manning and being able to sustain that before we start running into issues?
It's, I mean, the staff's been doing an amazing job. I mean, and just to give you an idea of census and capacity, I think it was about a week and a half ago, we had 14 in our long-term care and then 11 in our inpatient, which means that almost every single room, if not every single room, was used up, and some with double. So the amazing thing about the staff here is they're able to manage that. It's not without its price and toll, though. There's definitely burnout. It's stressful. I think Jennifer reported out on staffing taking double shifts. I mean, it's super hard. So sustainability wise, I think what we're seeing is a trend. It's been like this on the uptick. It's, you know, I think I've reported out a few times, there's a lot of times there's peaks and valleys in critical access hospitals where you have, either seasons or elements where you have a lot of inpatient and you just, you're able to manage those. But long-term, we're seeing quite a bit of patient days where there's the significant challenges on that. So staffing definitely is an issue. And finding, there's more pull from travelers. There's more people doing extra shifts. So certainly it's a challenge.
Thank you.
Can I ask a follow-up on that? And I think somebody alluded to it earlier. Is it people that are living here, or are they coming from other facilities here? I'm just thinking of our capacity in Petersburg too.
Just anecdotally, I think the majority of what we're seeing is in Petersburg directly.
Okay.
Yeah, so it is definitely something, whether it's staging, we're at that point within the population where we're starting to see some of these. But it's been ticking up quite a bit since last March, April. So almost a year where we're not even, I have a graph in my executive report where you can see the patient days, and it just shows the volume, and I kind of group it with swing bed, outpatient in the bed, acute care, and those are just terms, but they're basically people in the unit, in a bed in one of those capacities.
And then just out of curiosity, just remind me, because I forgot and I was trying to rack my brain about how many beds would be at the new hospital for long-term care and acute and.
Long-term, right now, this is a, interesting question, because initially we were just going to do the same amount. We just want to replace the hospital because we have an aging facility and we wanted to not increase the square footage because it's very expensive. We added one extra bed in long-term care and pretty much the same on the inpatient side. But I think we need to rethink that as we're looking forward, because I mentioned this last time, for the first time, we're considering a waiting list for long-term care. And you're right, it's not like we're seeing, from a push from other regions. This is really relevant and reflective of Petersburg.
When in the early talks on the new building, we talked about for long-term care that we set it up so that it could be expanded. Did it ever end up being that way?
Yeah, when we initially, the intent was that we would have a structure that we could have enough land that we would be able to expand out if we need to. But I think what we need to do is, since we are in a 35% design on the hospital, we haven't done 95% or 100%.
Right.
I think there's an opportunity here to really look at that, since we're not just seeing the peaks and valleys, we're seeing really quite a significant uptick in the duration. So.
And you're looking at hiring more people, another nurse or another provider to help with the expanded load?
Yeah, I mean, there's nursing, positions open, and we're filling those with the gap with travelers. So
Mhm.
we're certainly trying to increase our capacity. The nursing program, the RN program that our staff do here is amazing, our CNA program, but it's always seems like it's never enough.
Mhm.
Any other questions regarding that report? Thank you, Elizabeth. Moving on to pharmacy. Any questions regarding Elsie's report?
I have one.
Yes, sir.
It talks about the automated drug cabinet. Is that one of the dispensing units? Like they use the pharmacies, the big pharmacies?
Pyxis unit, sorry, if I can
No, there's a
respond.
thing, investigating possibly adding an automatic drug cabinet for controlled drugs. et cetera.
Yes, that's a Pyxis unit. Elisa, you on? Can't tell. No, okay.
Yeah.
It's been busy on the unit, so if, in case you're wondering where nursing is there, they've been, it's been busy. Yes, it's called a Pyxis unit. That's like a, for lack of a better word, it looks like a vending machine, but it's secured. It's
Right.
better, it's a better process, but yes, they've been looking at that.
Okay.
Any other questions regarding that report? Thank you for that report, Lisa. Chief of Staff, any questions regarding Dr. Burt's report?
No questions, but just noting that she also mentions the increase in older individuals in the community, and that tracks with the discussion that we just had.
Mhm.
Thank you, Dr. Burt, for that report. Clinic. Any questions regarding Kelly's report? Thank you, Kelly, for that report. She looked like she was ready to speak up over there too. Yes, go ahead.
There we go. So in the past 6 months, we made a change to the call schedule, which affects the physician call schedule of their days on call for the ER. And we used to do was every day it would change, and they were in clinic, and it was kind of created a chaotic environment for the providers, but also every day in our clinic as well. And so we made this shift where they're on call Monday through Thursday for 4 days in a row, and then Friday, Saturday, and Sunday. We've had some really good outcomes with that. We were worried about certain things, but it turned out we were worried that it would, not worried, we were wondering if it would change our availability in clinic, but it actually has seemed to improve our availability. People are even commenting like, I call and I can get in the same day, and they can get in with their primary care provider because we're still opening blocks each day that can get in with the provider. And then the provider that's on call, only 1 day a week are they in clinic as well, on the Saturday and on Monday, and the other days they're in the ER and covering the floor, and they're not pulled in 1,000 directions. And so it's been good. And even Dr. Burt put in her report that it has improved their quality of life, but we're also seeing like an improved workflow and process in the clinic with this change. So we're excited about it.
Could I ask just a follow-up question, kind of looking at that and thinking that with the increase in everything lately, has there been discussion about hiring another doctor? Or I know that you said CNA, there was another CNA that was hired, but more people on board, hands-on.
Bill mostly, but I think in the sense of, there hasn't been a discussion of changing from the 4-doctor model and plus 2 mid-levels with having Eric Hulebeck and Angela Manish. So we have 6 providers in clinic and then 4 providers that are on call. And I can, when we're fully staffed, it seems to manage our loads of what we need in clinic. Now, I can't speak to how that feels for the doctors being on call every day of the year. So you know, that's kind of a bigger question for the med staff, but
Yeah, I just don't
Yeah.
think that you have substitutes laying around.
Yeah, I mean,
Yeah.
we, we added the two mid-level positions. A couple of years ago, we had PA and Angela Manish as a nurse practitioner, and then the 4 full-time family practice physicians. And it's certainly a challenge of balancing sort of the budget versus the volume, of course, and making sure having the availability of the physicians. One of the things that Kelly tracks really well, and she could speak to, is access. And so just to give you a sense, they report out on the number of available clinics, and we monitor if we're at capacity. And so typically we still have anywhere from 10 to 12 to 13 appointments available on average every single day. So we're not at a capacity from a clinic standpoint, although, that's hard to say when the doctors are running around, especially on call and in our inpatient and acute care aspects. But from the primary clinic side, the data, that's one of the things that Kelly's really reworked, was the information on the report is looking at wait times and access to wait times and availability. And so if we were seeing increases in wait times and, lack of availability, then we would want, that's sort of the time we would say, okay, well, maybe we have more capacity, maybe we should look at different hours, maybe we add more weekend time, because space is also a challenge, and then if you add a doctor, you got to add an MA to room. And so there's lots of nuances there. So we did up staff quite a bit. And so we went from 3, 4 to 6 providers. So, and that helps balance the load.
tell a difference for access for sure in the past 5 years. The past 2, once we've had the 2 mid-levels, allows for a lot more availability in clinic on a daily basis because the doctors are pulled in every direction and they're really focused mostly on clinic. So, and then because we track every day how many appointments we need we track same day calls. So on average, Monday's our busiest day. Between 15 and 20 patients call to get appointments that day. Tuesday's the next busiest, Wednesday and Thursday a little bit slower, about 10 to 12, and Friday is about 15. So we know every day when we start, how many available spots we need to leave open. So when the morning hits, we open them and people call and we plug them in, and it's been good having that to track, and that's made it possible to do this new call schedule, because then we were able to know what actually do we need mostly.
Love data. That's great.
Any other questions regarding that? Thank you, Kelly. Moving on to community wellness. Any questions regarding Julie's report? None. Thank you, Julie, for that report. Dietary. Any questions regarding Jeanette's report?
Sorry to hear you've had such continuous problems keeping enough people producing the food.
And the food prices of the increased food prices. That doesn't make it easy.
Thank you for that report. New facility. Questions regarding the new facility?
Question.
Yes, sir.
I think it was in this one, there was a comment about having to reapply for the MRI permit. That's the wrong word, but was there a problem with the first time?
Certificate of need, I think, is that what you're talking about?
Certificate, yeah.
of need? No, we're still in process. We're working with the state on that. Jason, myself, and a consultant. And so we actually, the state has asked for more information. We are still working towards that. We had a meeting last week, and we should be finalizing that process.
Okay.
Yeah, chime in just a little bit and add to, some clarity to what Phil was saying. So we've struggled throughout this process of putting together the certificate of need application. Does the state just want to see the MRI? Or do they want to see the work building as a whole and the MRI? And it was, from looking at the regulations, a variety of things, conversations, we just didn't know how to complete that application. We didn't want to miss out on an opportunity. And last week's conversation with the state was a tremendous relief, in which they said, well, we do look at this as understanding you're replacing your entire campus, you're doing it in phases. This is phase one, and we want to see the whole building. We will process the certificate of need, meaning the whole work building. And so the $27 million that is being spent to build the work building and the MRI, we get to disclose all of that and process that through the certificate of need versus just say the $3 million for the MRI and the space for the MRI. And so that was a tremendous relief. I'm updating the schedules. We're updating some final pages with regards to that information and hoping to have some review of that on Monday with the team and be able to get that back out next week.
Thank you, Jason, for that. Any other questions? Okay, thank you, Justin, for that report. Quality report by Stephanie. Any questions regarding that report? Thank you, Stephanie, for that report. Any questions regarding the infection report by Rachel? None. Thank you, Rachel, for that report. Executive summary.
Hi, Phil. Providing my report. Any questions on my report before I'll highlight a few things since I've written the report? Always seems like there's other things to add on to activities. So the DC trip was very interesting. We did have all FaceTime with all the delegates. I went with the Alaska Health and Hospital Association, the executive team. And we had met with Senator Murkowski. We met with Congressman Begich, and we met with Senator Sullivan. They gave us a lot of time in the office, but that seems almost like a decade ago. A lot's happened since then. The things with the Medicaid budget is really, we focused a lot on preserving any cuts that are occurring. And, there just wasn't a lot of information that was realized or understanding. And then with the conference on the American Hospital Association, we got to hear from many representatives and senators who sit on these committees that talk about Medicaid and the cuts. And some of the cuts are related to something called provider tax. Alaska doesn't have that, so we will not have that if that goes through. So that's a good thing. It is a real strong focus on areas of expansion. So any Medicaid related to expansion and things to make it a little bit harder to stay on Medicaid. Work requirements is not something that's been talked about. I'm sure if you've been tracking the news, these are not unknowns. Determination and redetermination of an eligibility on Medicaid, which is hard right now, and that's a pretty significant burden or administrative burden that would be challenging to keep up with, and states will get penalized on that if they don't stay up with that. And that's going to be a concern of ours because, states maxed out on a lot of those capacities. So we worry about that. We also identified tariffs that we were seeing in our facility related to supplies and delegates did not know about that. So we have been sending, I asked our staff to, if they catch any invoices related to tariffs, that we were instructed to send that to the delegation, which we've been doing. And so things like lab supplies, medical supplies, anything related to the work building, any of that that has tariffs in the invoice, we were instructed to let the delegation know, so they're aware of that. And that's something that we brought up that was an unknown at the time. But other than that, from the state legislative side, the budget's really thin, price of oil is low. So, from a capital budget standpoint, I didn't expect much. And, that's kind of what we got, I think, on the budget side, from at least from the facility. We still put in appropriations on the federal side through Congressman Begich. And we have, we'll have to wait and see how that works its way through the legislature. Prior authorization bill that Jared Kosin, the CEO at AHA, helped put together in collaboration with the payers such as Premera and Division of Insurance, actually passed, which is sort of unusual. It's a 2-year session, and typically bills take 2 years to go through. If they're going to pass, it passed in 1 year. Is very well supported, and this is really to focus on a prior authorization. So if you have an authorization or you have a chronic disease that needs recurring authorization, it's to reduce the barrier and to actually improve that process. And that's something that has been it's a challenge, a constant challenge. Our staff work on that a lot, and it's hard to get those authorizations, sometimes to the point where they have to cancel an appointment, or they have to reschedule an appointment, and then it just delays care. And so that was a really positive thing, and that'll take a little bit of time. I think by January it'll go into, and it'll be enacted, and it'll have some policy around it. So that was really well done to Jared and AHA. So that was a real positive thing, I think. It was very collaborative. Not a lot of opposition at all that came through on that. And today, this week, Home Health, I just want to kudos to Home Health team. They had their recertification survey. These occurs every, I think it's 3 years for Home Health. I can't kind of get confused on that. I think it's 3 years, 3-year recertification. And they came unannounced, as they would do. And they were here this week, and they just did the exit about an hour and a half ago. Amazing work on that team. Well, more information. It was one of the quickest exit interviews that I attended, so that was good. So congratulations to Laura and the team for really a lot of hard work there. So, and those are pretty challenging, especially coming in with graduation week and Memorial Day and lots of things going on in that department. To highlight, I think this is mentioned a couple of times, but just bringing the accounts receivable in-house. One of the, and I mentioned this on KFSK today, but one of the things that I thought was very interesting, we're tracking data. I know since you like data, Heather, one of the things that we look at is the accounts receivable. And since I've been here, we've been talking about accounts receivable and managing those. They've always ticked up higher, and it's hard to keep those down. And bringing that in-house and having the finance team really be able to work those. One of the things that we saw was with this increased volume that we've been talking about in the last month, one of the things that's new was that we've been seeing a downturn in the AR, which is great, because that typically we would see increased in volumes, increased in charges, and then the accounts receivable would go up. And the only times that we would see accounts receivable go down is when there's sort of a lag. There was some time, not a lot of patient volume that can catch up on the billing and claims. So we're seeing that the accounts receivable is going down at the same time that patient volume is going up, which means that they're really working hard and they're getting those claims in, and they're doing it in a timely fashion. So I also reported out at KFSK that we'll have people on site here in Petersburg, a live person that you can talk to from Petersburg that can assist you in any questions about your claims, and they have staff related to that, and not somebody outside. So those are really good things, positive things to report out from the rev cycle and the finance team. Jason and Joel and Carrie have just been, the whole team there has been working really hard with that. And then specialties, one of the aspects is continuing specialties, keeping some continuity with the same provider. So we have Cameron French coming up, I think for the third or fourth time, when? June
June 9th through the 13th.
June 9th to the 13th. So that's exciting. Dr. Cap has been coming on a regular basis. She was here for an extended time, so that was great for optometry. Very happy to have Dr. Sonkas, our telepsych psychiatrist that's coming here on site. Very happy to continue that. We have not, we're working on a process, but I feel like that we've been struggling quite a bit on scopes, and we've had some fits and starts with that, and that continues to be a struggle to get an established provider there, but we are working on that. We have some good leads. Jennifer Briner has a couple of good leads, and we'll have more information to report out on that as that goes forward. I think that's it. Any questions on the work building? Of course, transition planning, getting the teams ready to go up there. We have some dates and times I should probably report out on with the work building. My understanding is our commissioning will occur here soon, this month in June, and we'll be able to, our furniture will start arriving sometime in July. MRI will start arriving in mid-July or so, and then we'll have sort of a move-in transition time. I call it a soft opening, potentially at the end of July and August, where we'll have public health and the departments over there getting our workflows established, and then we'll have a grand opening for the community sometime in September is what I'm thinking. We wanted to invite Senator Murkowski since she was a primary funder and got the appropriations rolling, so trying to work with her staff on finding a time that's available. But that doesn't mean we won't be open with the community as well, so we'll have information going out there throughout the summer.
Could I ask a follow-up on your trip to DC? Did Sullivan talk about an Alaskan executive order with you?
I don't recall that. Yeah.
All right. I was just curious because Trump signed an Alaska executive order, and I'm wondering how that's going to benefit us if we're seeing it in so many different ways.
Oh, is this related to the oil?
I believe so,
The oil
yeah.
pipeline. Yeah, I did read about that. He didn't talk to us about that specifically, so I'm not.
Just wondering if there's
That's
any
not my-
benefit to us
Yeah.
for that. And then, can I ask about the AR, or we could hang on until Jason is there? But I was curious, where are we seeing that decrease? Like which month specifically? The 20?
Oh, these are daily ones I see this is probably
Okay.
the last 3 weeks or so. I
Okay,
think
so it's
in the
May.
packet, Jason will go over the ones up till April. Report that I have on my executive, I have a graph directly from Cerner that looks at AR days. And that is 81 as of May 19th. And that's dipped up and down in the 70s. So you can see that the graph looks, you can see it starts in February. If you look at on page 36, it starts, there's a graph that shows sort of the daily change from end of February to the end of May. And you can see that it sort of climbs up, and then it kind of had this nice gradual trend that's going down. And if you look on the page before, you can see the volumes and the patient days skyrocket at the same time as the AR days are coming down. That's mostly in May, so it's not going to be reflected on the financials necessarily.
Ask sorry, I'm asking so many questions. What the difference is between the net and the gross for
Jason,
AR?
you want to?
Yeah, I'd be glad to answer that. So to me, measuring gross AR, looking at the gross number is the most accurate. Because we're looking at the total dollars outstanding in accounts receivable, and we're dividing it by our average daily revenue of total revenue. And so it is the most accurate. Net revenue, to explain, when we calculate net revenue, we in accounting look at what we believe we're going to write off when the claims get processed in the future. And we have a policy that otherwise states that, certain balances outstanding over so many months are reserved for. And so net accounts receivable factors in that reserve. And so it can be misleading in a situation where accounts receivable is growing, it's kind of getting out of control. Our accounting policy kicks in with us or with any other hospital, says you've got a reserve for that. So the net days in ER might not look as bad as they should be, but when you look at the gross, you're seeing the whole picture. And so I tend to focus on the gross revenues, because it's our job in business office to collect the whole claim, not just the estimated portion of that. Does that help, or
Yeah,
can
that
I
helps.
explain it a
Thank you.
little more? Okay.
Phil, just
Are you
one
done, Phil? I didn't want to.
Phil, I just had one other follow-up question that has to do with your trip. Was there anything that you came away from back there with any of your visits that gave you any positive hope that there's any money for a new facility down the road here anytime soon or looking forward?
I mean, the only thing that I you gotta look at the experience in the committees that the delegates sit on, and, Congressman Begich sits on the transportation and infrastructure. So, potentially there. But it's from a funding standpoint, I didn't get either. I just think there's a lot of uncertainty in what's happening in regards to the budget, and related to capital and related to operational. So I just when I left there, I got the sense that there just was unknowns, lots of unknowns, and I heard that across the board. Yeah.
Thank you. Any other questions for Phil on his report? Thank you, Phil. Financials?
Yeah, I want to just kind of dovetail into some of the things that Phil was talking about there. Certainly many people, board members, people in the community may be watching the media and hearing about certain legislations, one in particular, the big beautiful bill, and hearing comments about how it's going to impact healthcare and things of that nature. I just wanted to say, every single year, Democrat, Republican in office, doesn't matter, there's always proposed cuts to reimbursement, because federal government, our country, is trying to figure out how to provide services to the baby boomers that are retiring and aging in the retirement stage. And this has been going on for some time. So proposed cuts, proposed changes to health insurance benefits, things of that nature come up every year. And there have been cuts. We experience cuts every single year. But there's also different opportunities that come up that help us to be able to do things. And I've been in the industry for 32 years. And when the Medicare, Medicaid programs were first created, the federal government required that hospitals provide a cost report every year. That's not changed. So we do that, and the government uses those cost reports to determine reimbursement. And in our current state in the industry, they tend to like to reimburse hospitals at about 98% of our operating costs. They pay a little less, and then they come along with special little programs to get us to a positive bottom line. And those programs are really the way that they get hospitals to do what they want. And let me give you an example. You might recall back in 2010 or 2012, the federal government said, hey, we're going to give you some money to implement an electronic medical record. We probably did that, and we received some significant grant funds. And then during COVID from 2020 to 2025, we're still applying now. We're getting funds for COVID and different things along the line. So I just wanted to point out that the media will often talk about some of the negative, most inflammatory stuff, but not necessarily explain the whole picture, things of that nature. I'm an affiliate of a national consulting firm called Stroudwater. You've worked with them in the past, and so I forwarded a kind of an update from them with regards to the legislation, give a more full picture. And I just want you to be aware that Phil and I are very much in tune with these things and trying to understand how they will impact us positive and negatively. But, you know, I joined the organization a couple of years ago, and at the time we were very concerned about some things, and I began implementing a financial improvement plan, and I have not stopped and I won't stop. There is big change coming ahead, and we need to get everything optimized in our organization. And I would say that we've accomplished many great things over the past couple of years. We can see that in our bank account, that we have restored it back to what it was prior to COVID, and we continue to add to it. And we're doing a variety of things. And I'll talk about those as we go through this presentation. But I wanted folks to be aware that we are looking at the full picture. And, you know, we're adjusting things already to be prepared. And I would say the number one most important thing that we're doing is building a building, because that depreciation expense going through our cost report will do a tremendous amount for us. So taking the courage to do that will be very beneficial to us over the next 20 years. Coming to the financial report. So the clinic visits, you know, there was a little bit of conversation here about how is this impacting our medical staff? How is this impacting our staff? And I think it's helpful to kind of glance at some numbers. And I would say, you know, first of all, a little bit of volume everywhere does add up. So I don't want to discredit anything, but it's helpful to kind of look here. So we can see in the clinic visits, 833 in April. Year to date, that's 8,418 versus the prior year, 8,055. So, you know, it's up not quite 400 visits over the 10 months of the year. It's a little bit, but still doable with our staff. Radiology procedures, very strong. Lab test, as we indicated, a little lighter because it's not a health fair year. Rehab services are up, doing very well. A full team there. Home health visits, strong this year, 1,888 compared to 1,300. And then emergency department visits, not a significant change, a little bit from the prior year. You know, maybe 30 visits during the winter months. We typically see around 60 to 70 visits. We can see in the summer months upwards of 90. So between the clinic visits and the ED visits, not a little bit of increase, but not a substantial amount. Where we start to see the big impact, of course, is acute has been strong. We've seen 303 patient days for acute versus 274 in the prior year. And then the swing bed, 736 compared to 308. The thing to keep in mind, this is going to keep the nurses and the CNAs busy. The physicians don't round on them every single day when they're in a swing bed status. And then we have created this new line here called the ICF day, 260. This is when we have a patient who's waiting to get into our long-term care unit. We don't have a bed, we're maxed out, but we keep them on our swing bed unit until one frees up in long-term care. And we wanted to carve that out so that we can see, you know, who's the payer. If they're a true swing bed patient, Medicare is going to pay it quite a substantial rate, a couple, you know, $3,000 or $4,000. If they're an ICF day, it's going to be paid by Medicaid. It's about $850 a day. Okay. And we come down to the long-term care, 4,110 compared to the prior year, 4,102. You know, you say, well, we're not really seeing that many more long-term. Oh, we're at capacity. You know, our average daily census is 13.5, and I think our maximum is 14. So that's why it's spilling over, and we're seeing additional days on swing bed and on the ICF. We're trying to keep them in the community until we can get a bed freed up. And, I once, 100% agree. We haven't built the new hospital and we already haven't built a big enough long-term care unit. As we really reflect upon what the future lies in store for us, baby boomers are aging and they're approaching that 85 years old when typically begin seeing some in long-term care, and we will see a substantial increase. We've actually been dealing with, over the last decade, really low census in long-term care. We've been closing across the country long-term care facilities and things of that nature because there's not been enough census. Here we are, the baby boomers are aging into that bracket where they'll be using that. And so I do think swing bed and long-term care services will increase substantially over the next 2 decades. And it will be wise for us to have enough space in the building. So, okay. Coming down to the income statement, inpatient, as was reported, doing very strong, $729,000 in revenue compared to a budget of $335,000. Outpatients, fairly close to budget. Long-term care, just a little bit above budget because we have a full census. Clinic, right on par. And home health dipped just a little bit compared to budget. It's still stronger than prior year. Deductions looking very good. We actually settled on the cost report from the final settlement from the prior year, the 2023 cost report. And in the course of that, we were able to change some statistical reporting based on some questions that was asked by the auditor to our favor. And so we received an additional $454,000 as we finalized that year's cost report. So you see that there, it's in brackets, but that indicates that it's a pot. It's adding to, it's decreasing our contractual allowance, adding to our bottom line there. So excited to see that. And let's come down here. 340B program that we've got kicked off. We've been working on it for a year or so, a couple of years, and finally got it in place. Revenues for last month, $115,000. Our expenses associated with that would appear down here under purchase services and also supplies with regards to pharmaceuticals. Usually run about 50% of the revenue. So, that made for us not quite $60,000 last year. So that's when I talk about how are we preparing for budget cuts and for these things that are coming about, as the Medicare Trust Fund tries to spread with the dollars they have over more people. Getting 340B in place is very important. And then working with Phil, working with the legislature to expand and protect 340B will be very important as well. Grants and all that looking good. You can see in our expenses are running a little higher. That's not a bad thing. We're, coming up with the staff and the supplies and things to provide care, and we have added expense for the 340B. But recall that we are reimbursed for our inpatient services, swing bed and that, based upon costs. And if our census goes up, but our costs remain the same, then we end up refunding Medicare. So it is okay that if our census goes up, it's only natural that we need more staff, more supplies. And so our costs are going to go up a little bit. We won't have to refund Medicare as much money. It's just the way the program works. If volumes go down, Medicare still pays us our costs. It's kind of a buffer to prevent us from going too deep into the red. But when things get positive, they share in the losses, but they share in the gains too, and we remain in existence. But what's important, working with a cost-based reimbursement is totally opposite of working in like the traditional business and entrepreneurial business, because you're dealing with the government. But it's important for us to understand our costs, to be prudent with our costs, and an important element of our cost in the cost report is depreciation, as I said. So being able to depreciate $2.5 million per year next year, I think that's what it is, if I remember my numbers correctly, might be 1.5, adds to those costs, and it will increase our reimbursements for Medicare and for Medicaid. So contract labor, So we're running a little bit above budget, about 389,000. But you can see here our net income for, not net income, our income from operations, 739,000 above or positive, and just a little bit above budget there. So I do think as we get to the end of the year and we're able to fully estimate our cost report liability, we might see that improve just a little bit. I've been conservative in the numbers that I've been reporting there. Not quite anticipating. I mean, we've had strong growth and so it's hard to estimate those. Investment income down a little bit. A lot of clamor about tariffs and that impacted the market, but they're back up. I'm sure we'll see different numbers in May. Interest expense, and of course, been recording here in the bottom line, the capital project. And so we have a very strong monthly financial statement. We have a very strong year to date, we're recording net income $14.8 million compared to a budget of 10. Two things embedded. That one is about $11 million with regards to the grant for building the hospital, but then also we had that $3 million that were recorded for employee retention tax credit. Take us a couple of years to get that, but once again, there's another one of those projects that we trying to find. We know cuts are coming. We're trying to gather up everything and optimize every opportunity for us and get things strengthened. Okay, moving on to the balance sheet, you can see cash, 1.6 million in our general accounts. It keeps creeping up here in May. Investments were sitting at about $1 million. And so Phil and Joel and I are trying to convince Margarita to let us move some money from cash into investments there because we've been accumulating some good cash. Now it is down a little bit. You can see from the prior month, if you recall, there was a period of time in which PERS had been hacked and they weren't collecting the money from the retirements. And so they were sitting in our bank account, but they got their system fixed and we quickly got those monies transferred to them and that's all taken care of now. Patient receivables, 7.6 million as of the end of April. The end of March was 7.8. This marks the height of it. Recall, we discontinue services with HRG. I think it's on the 22nd of March, right at the end of March. And so in April, we did not, we saw an increase in revenue, but actually saw a decrease, as Phil explained, in accounts receivable because the business office stepped in and was very effective from day one. Typically you would anticipate, well, maybe there'd be a few weeks or a month that we would have some rough spots and things would grow a little bit. And then they hit the ground running and they're doing a wonderful job. And we're seeing increased collections in the month of May, and we'll see more reductions. And we're just, planning on building on top of that success until we get down to about 65 days in AR. This is the piece I want to talk about, the contractuals. So you can see here on the balance sheet that we have this reserve and allowance for contractual for bad debt, 2.7 million. This is an estimate that we in management make where we look at the accounts receivable that are outstanding, 30, 60, 90, 120 days or more, Medicare, Medicaid, inpatient, outpatient, variety of metrics. And we estimate how much we're going to write off. And when accounts receivable grows, it's not being managed tightly, this contractual allowance gets bigger. And as a consequence, it makes that net days in AR, it doesn't change that much because we reserve for it, even though we didn't collect it. So it's like I said, it's not quite as accurate to look at the net days in AR because the contractual allowance is set by us. Other receivables, I believe this has to deal with the employee retention tax credit and also probably some things with regards to 340B. So other than that, looking over here on the accounts payable, remaining consistent with prior months in terms of what we owe each month. We were current on our bills, new facility, payroll, all of those things. So nothing out of the ordinary there. A couple statistics here. We can see here the gross days in ER, the net days in AR. The gross, we were hitting at some points upwards of 90. I think there was a point that I recall, oh yeah, 96 right here, almost 100 days in AR. In the end of March, April is 87. When we gave notice to them back in, I think it was in January, they kind of gave up, and so it crept up and quickly seeing it come back down. But the standard we want to get to is 65 days in AR. Yeah, okay. Those are the main things with regards to the financial performance of the organization. Of course, big projects that we're trying to complete will be the budget here in June, the certificate of need. We're working on renegotiations with some different payers, making sure that all of our payers are equitable, meaning there's no one payer that has a better contract with us than another, so that whoever the employer is or whatever agency in the community, everybody's getting the same discount from the organization. So another one of those strategies, we've got to make sure that we have equitable contracts from our commercial payers, and everyone is paying appropriately as we're going into lots of these changes. So let me pause there and see if folks have any questions.
I have a question.
Go ahead.
So with the cuts in Medicaid that may be happening and the tariffs, and I'm trying to take a look at the bad debt across, are they able to pay their bills? And so then I take a look at this last page, and number 3 has bad debt as a percentage of the gross revenue. And I look at the negative 495 and 0.2%. Is that a good thing or a bad thing?
So that was on the last page there, the statistics page.
Correct.
Yeah, bad debt is percentage. I'm seeing the 2.3%.
Yes, and then the change, if you go all the way, that's cumulative.
Yeah.
Okay, I'm sorry. I answered my own question.
So year to date, our bad debt is 1.5. I know nationally, over the years that I've been doing this, if your bad debts are below 3%, you're doing very well. So we don't have a significant amount. We certainly do try to do things to collect, but even in some cases when we have bad debts, we can report them on the Medicare cost report if it's a Medicare beneficiary. So there's a few things that we can do there. But at the end of the day, our mission is to provide care regardless of people's ability to pay. I wouldn't say that we have processes that are weak in any nature, and we're collecting better than industry standard.
So when you budget, sorry, this is Heather again. When you budget, do you budget at 3%?
No, we kind of look at our historical for our organization versus using the national average on that. So we try to dial that in as best as possible.
Okay, thank you.
Question. I find the
Go ahead,
best
Joe.
way to collect on bad debts is when people call in to schedule an appointment. If we've sent an account to collections, then we ask them if we can discuss that before we schedule their appointment. We won't turn them away from appointment, but it's just a good time to talk about how can we resolve that account.
Joe?
Yeah, Jason, this is Joe. On the balance sheet, page 42, like just taking the first row there, cash, 1.65 million for April of 2025. The next column over says March of 2024. Is that a typo? Should that be March of 2025? Is that the month
Yeah,
before?
typo. I think it's supposed to be 2025.
Okay,
previous
so
one.
it's just, so the first column is current, and it's just a comparison to the previous month then?
Yeah. And then the June 2024 is at the end of our last fiscal year.
Okay, yeah, that's what I thought. Okay, thank you.
And then, of course, you can see April 24 for what was it a year prior.
Okay.
Any other questions for Jason? Thank you, Jason.
You're welcome.
Moving on to new business, medical staff bylaws, action required.
Dr. Burt's here, but basically it's just a recurring, we're supposed to renew the bylaws every couple of years and just sort of that process. There's just a couple of language changes related to credentialing for telehealth. And then I think just an edit under MedStaff voting criteria. So just a little cleanup language, a little improved process. It was approved through MedStaff already. And yeah, just requires a recurring approval. Update.
Go ahead, Joe.
Yeah, I just had a question about that, Phil. I seem to remember in the past when changes have been made to the bylaws that, that if I remember right, as I was on the bylaws committee, we would meet and sometimes the attorney would be there to discuss the changes to the bylaws. I guess I'm wondering why this is different. Are these changes like fairly minor, or
Yeah,
is there urgency where?
Yeah, they had legal input. It did. I think you're referencing the board bylaws. This is just MedStaff bylaws. It's just a different, same concept, but just different governing body. The MedStaff is a self-governing body, and it's just, requires renewal, whereas the board bylaws, I believe, we redid that a couple of years ago.
Okay, thanks for the clarification.
Yeah.
I would entertain a motion to approve these if someone would do that.
This is Heather, and I will make a motion to approve the bylaws.
I will second it.
Any discussion? And this is the medical staff bylaws. All in favor?
Aye.
Aye.
Any opposed? None. Okay, next meeting. Scheduled for June 26th, 5:30 PM. Do I have a motion to go into executive session?
This is Marlene, I move to enter executive session to discuss legal matters, medical appointments, or medical reappointments.
I'll second that.
All in favor?
Aye.
Aye.
Aye.